Welcome to the NHPCO's webinar. During the presentation, all participants will be in a listen-only mode. Afterwards, we will conduct a question-and-answer session. At that time, if you have a question, please submit it using the chat box on the bottom left side of your screen, or if you are joining us by telephone, please press star 1 on your touch-tone phone to ask your question. These instructions will be repeated later in the program. Also, during the webinar, if you would like to enlarge this slide presentation to full screen, you may do so by clicking on the green icon located in the top right corner of today's slide presentation. By clicking on this icon, you will be able to enlarge the slides and select full screen mode. Please note, in full screen mode, you will not be able to utilize the chat box. While in full screen mode, to return back to your normal screen, just press the Escape key on your keyboard. As a reminder, today's conference is being recorded. I would now like to turn the conference over to Jill Norris. Please go ahead.
Good afternoon, and thank you for joining us for this NHPCO webinar entitled Responding to Suicidal Intent or Completion. Our faculty for today's webinar is Elizabeth Arnold, Ph.D., MSW. Dr. Liz Arnold is currently an Associate Professor of Psychiatry and Behavioral Medicine and Social Sciences and Health Policy at Wake Forest University School of Medicine in Winston-Salem, North Carolina. She is also a faculty affiliate with the Maya Angelou Research Center for Health Equity there. Dr. Arnold has an MSW from the University of Georgia and a doctorate in social work from Florida State University. Dr. Arnold has no relevant financial relationships to disclose. And now, I'll turn the floor over to you, Dr. Arnold. Please go ahead.
Okay, thank you, and I'd like to welcome everyone to the webinar. I'm going to just start the presentation by telling you a little bit, although I have no conflicts to disclose. I did want to say that part of the information that I will be presenting is based on a grant that I've received in the past from the Project on Death in America, which is part of the Open Society Institute, so I'd like to acknowledge them. The first thing I'd like to do is just give you an overview of what we'll be talking about today. The objectives you'll see there on your screen. We're going to look at the different issues associated with suicidal intent among hospice patients. And then we're going to talk about intervention, engaging, and just how to respond and what resources may be available. The presentation is going to vary in that I will be talking a lot at the beginning about some data and some research that I've done in this area, and then the second half will be more on the clinical application of the findings to the work that you do in hospice setting. All right. Just to give you a little bit of background on the presentation and the work that I've done in this area, the information that I'll be presenting today is based really on about 20 years of work that I've been doing on this topic. I started out early in my career, about 20 years ago, working as a hospice social worker. And although I don't work in hospice anymore, I've continued to work throughout, particularly the earlier part of my career in end-of-life care. Started out in hospice social work. Then I worked in a psychosocial oncology program, a health psychology program, including doing work on a bone marrow transplant unit, and then transitioned a little bit more in the second half of those 20 years to doing more work on suicide in general. So we'll be coming to this presentation from the perspective of someone who's worked in end-of-life care, but who's also more recently worked with people who have suicidal ideation in just a variety of different settings, right now predominantly mental health. So that's a little bit about my background as it relates to the presentation. The first thing that I'll be talking about today is my dissertation, which was done on factors that relate to people wanting to hasten their life at the end of life. And I'll be telling you a little bit more about that. And if you're wondering how in the world did I decide to do a dissertation on that topic, I will say to you that all the work that I've done has come out of the work that I've done in providing direct care to individuals and families at the end of life. And when I first got out of my master's program about 20 years ago, I started encountering situations that where people had shared with me that they had thoughts of wanting to hasten their death in their life, and those types of conversations. And maybe those of you who are out there feel more equipped nowadays than I did 20 years ago, but I felt very ill-equipped. I didn't know how to handle those situations, and because of a few cases that were very pivotal in my career, I decided that I wanted to go back to school and get a PhD and try to study this issue. So I went into my doctoral program in social work knowing that what I really wanted to learn how to do was study these issues and really be able to understand if someone is at the end of life, what factors would play a role in whether they would consider hastening their death. And I'll typically use the term hastening death, which could really imply assisted suicide or suicide, but for the most part we'll be talking about suicide. But if you can bear with me, I'll probably be using that term because that's the one I'm most familiar with in my work. But feeling ill-equipped really led me to try to explore these issues further. And like I said earlier, I went into my doctoral program working on my dissertation on that topic, and that's what I actually ended up doing, and I'll be sharing those results to you. I'll give the other disclaimer today that I don't claim to have all the answers here. I can share with you what I've learned over the past 20 years and what I've seen in my work with individuals and families. But if you're hoping to have all the answers, I hate to disappoint people, but I don't have all the answers. But I'm sure I've had some of the same struggles and challenges that you have in working with people at the end of life. So hopefully we can have some dialogue, although it is a webinar and I'm used to doing primarily presentations in front of live audiences. Hopefully through the chat and other means we can have some dialogue about these issues. One of the main points I want you to leave the webinar with, hopefully, is to think about these issues that come up with patients and families before they happen. And I think that was one of the things when I first started off, is that nobody talked about these issues, no one acknowledged that they existed, and it made it really difficult to be able to practice effectively with folks. So that's one thing I would say is to really start thinking about these. I'm sure you already have, but I think it's important to keep these on our radar. With that, we'll move on. In the first section I'd like to talk about today is risk factors for suicide. And I'm first going to talk to you a little bit about the suicide research not related to end-of-life care. So if you see there on your screen, there are some facts about suicide. And as you can see, suicide is a pretty big public health problem, and we lose a lot of people in the United States from suicide. Fortunately, a lot more people think about it than actually act on it. And so you've got about half the people that make a plan actually make an attempt. And as you see, we lose quite a few people every year to suicide. The next slide is from the CDC, and it's just some pretty recent information about suicide. And as you see there on your screen, there are a variety of risk factors for suicide. One of the main things I think we need to look at in general suicide prevention is the first bullet that you'll see there, the history of a suicide attempt in the past. And we know that that's a big risk factor, not just in mental health, but in all different types of settings, including, I would say, probably at the end of life, and we'll talk a little bit about that later. And in particular, if you look at mental illness, combining that with alcohol and drug abuse, those two combined are very large risk factors, as well as looking at that bullet there you see on physical illness, which we'll talk more about later. The groups at high risk, you've all probably heard about men, but I think it's really important to look and acknowledge that individuals in rural areas we're starting to come to believe and be able to document that there's a risk associated with being in a rural area. And I'm sure some of you are probably in hospices that serve, if not predominantly, at least as a part of your population. And then this is something fairly new that I hadn't seen until recently, the issue of people from retired military. We know active military and people immediately coming out of the military that we've seen some high risk, but these even include people that are older who have been in the military years ago. In terms of suicide risk, in terms of age, Obviously, the older age group we've always seen consistently over time. These are some older numbers. But one thing that's important when you look at general suicide research is to acknowledge that firearms tend to play a huge role in suicide attempts. And we'll talk more about that later in terms of things that you may be able to do, particularly those of you that are going into people's homes. But firearms are a big risk factor for suicide. The other important thing that I'd point out is that males tend to be much more successful in their attempts, and this has been consistent across the years, I think, when we look at the suicide research. But women are much more likely to try suicide and be unsuccessful in that. So I'd like to ask you all to respond to the first polling question so that I can get a sense of what discipline you're in. And I know that you're probably calling in from, you have multiple people in sites, but if you can now just take a few seconds to click on your polling question so I can get a sense of the audience. All right, it looks like that predominantly we've got social workers, so that would be about 44%, and then followed by nursing with a small number of people from other disciplines. So that's helpful. So far, 41% social work, 26% nursing. All right, and we'll move on. The initial study that you see described on the screen is the study that I was talking a little bit about earlier. That was my dissertation research. And to give you a little bit of additional information about the study, this was all done in a survey format, and the surveys were done through the mail. They were mailed to people who had self-identified as having, and that's the actual word I use, life-threatening illness. I did not use the word terminal illness because, as you know, in hospice, that tends to be a very time-specific prognostic indicator that a lot of people we might have missed who didn't have that but felt that they had an illness that was life-threatening. So I did use that particular term, and I asked people to respond to the following question in the study, which is, have you considered hastening death as an option for you in the future? And that's how I divided the sample of people into people that I called contemplators and the other group of people who I called non-contemplators. And so these were people that responded to advertisements or contacts through people at community agencies that serve people who might have been appropriate for the study. And they contacted me via phone, telephone, or email, or regular mail, and notified me that they were interested in participating. They were mailed a survey. And we collected our data through those means. So if you see there on your screen, and this goes back to what I was talking about earlier about trying to sort out who are these people and why do people at the end of life consider making these decisions. We did some standardized measures of depression, social support, hope, pain, and anxiety. So those were all standardized scales that were included in the survey packet with demographic information. And what I found was that the factors that distinguished people who would consider contemplating their death from people who wouldn't were depression, social support, and hope. Interestingly, a little bit different than what I had thought, pain for my study did not play a role. So the level of self-reported pain using a standardized measure of physical pain did not play a role, nor did anxiety. And going into it, I thought that depression was going to be one of the biggest factors, and that ended up being true. But I was really surprised about the pain, and I thought anxiety would play a role. But that's what I found in that study. And the other thing I'll throw in about that is that the sample was pretty diverse. I mean, we had people who felt strongly on both sides of the issues, but in order to get people who were considering hastening their death, who had a life-threatening illness, we had to tap into ways of identifying those people. So 1/3 of the people in the study were recruited through the Hemlock Society, which I'm sure most of you are familiar with. They have a national newsletter, and we advertised it there, and we also advertised it in 2 state newsletters. So the sample had pretty much 50-50 people contemplating and non-contemplators. I'm going to move on to sort of what I would sort of call the second phase of the work that I've done in this area, which is the project I mentioned at the beginning that was funded by the Project on Death in America, which is part of the Open Society Institute. And I had received a grant. This part of the project was about 10 or 11 years ago. And so some of these data that I'll be presenting are not really, really recent, but I think as you'll see as I update you on what's come out since I've done this work, that you'll see there's a lot of consistencies in the findings. So in this project, what we did was two parts. The first part, and this was a collaboration with the Carolina Center for Hospice and End-of-Life Care, and I worked with Judy Lynn Person, who some of you may know from NHPCO. She was at the Carolina Center back then. And we collaborated on doing a survey of hospice social workers in North and South Carolina who were members of the Carolina Center organization. And we sent out a pretty detailed survey asking people about their own experiences working in hospice settings, and we also asked them about hastening death cases. And that's what I'm going to be spending quite a bit of time sharing with you, the information, which I think is hopefully going to be relevant to the work that you do since it was in a hospice setting. We took all that information that we gained, and we developed an interdisciplinary training on end-of-life issues that arose from this, including the topics that we'll be talking about today, as well as some other related topics. And we did trainings in North Carolina and South Carolina to hospice social workers in those two states. The survey that we used for the data collection was a survey that I developed specifically for this project, but to make sure that the questions were relevant and appropriate for the population, I did have the survey reviewed by over 20 experts in end-of-life care, and this was done predominantly at a national conference where there were different experts there who agreed to review and give me feedback, and I incorporated that feedback into the survey, the final document that was mailed out. As you can see, we mailed it out to a little more than 200 people who were employed by hospices in those two states. Unfortunately, we did not have a really great response rate. We had about a third of the people responded, and as you'll see, we've got quite a few cases, and I'll be talking to you about those. One of the things that I wondered at the time was why we had so few people actually respond to the survey, and I'll throw out my theories, and some of you may have thoughts that you can share on that as well. But I think that people had a lot of concerns about confidentiality. Would we adhere to what we were saying that we would do in terms of keeping the confidentiality of people who share the information, adhering to those promises, which we did. But I think people can be a little uneasy talking about these issues, particularly writing about them. I think in general we still have some discomfort with this topic. It's not probably one of the easiest things to talk about and to think about. And what I asked from people was to fill out a pretty large packet that was pretty involved, so there may have been people who looked at it and thought, I didn't really have the time, to devote to that. So I think all those things, and maybe some other things I hadn't thought of, played a role. The slide that you're looking at now is a description of the hospice social worker. So this is not the patient, so I'll be talking about that in a little while. But this is just to give you a sense, because I do think that because we collected our data in North and South Carolina, there's some bias of the sample. I mean, obviously these are two southern states, and we could all probably argue that North and South Carolina are not in many ways representative of the entire country. And I think if you look at the demographics, you'll see that. But I think if you look at hospice social workers in general, we're probably pretty close to national data in terms of most of them were female, as you see, variety with age, predominantly Caucasian, and we had most of the people that we surveyed had a master's, but some, about a fourth, had a bachelor's degree. And then you see there that variation of the paid social work experience, and then a slightly lower number of hospice-specific years of experience. The next slide here is an overview of the hospice programs, and these were the programs where the people who filled out the survey worked. and you'll see that the information on the census, and I think probably this is pretty consistent that social workers would see the patients about 2 times per month, and the caseload size there. I was also interested in who social workers reported to because that can maybe play a role in terms of training and perspective. So it was pretty split between nurses and social workers. And then I just was curious as to who ran the hospice agencies, and you'll see there that's broken down. And then if we look at this rural-urban issue, I think that maybe in North and South Carolina we may have more that serves rural areas or combos than maybe some other states. So part of this was not only trying to understand what these cases involved where patients considered hastening their death, but I also wanted to better understand how these issues were dealt with within hospice settings. And so I asked people to tell me sort of about the procedures to deal with ethical dilemmas. And most had, I'm sure all had team meetings, mostly weekly or biweekly. And I asked, what do you do when you have an ethical dilemma in your hospice setting? And as you can see, most of them use their team meetings with their interdisciplinary teams or their individual supervisions. Now, about half of them, as you'll see, had ethics committees, and then people had other specific mechanisms that really varied in terms of how they would resolve ethical dilemmas. But I think we're really looking at, not surprisingly, that people in hospice use the team to bring back issues that are difficult for them to try to resolve. One of the things that I was interested in, and this comes from my social work background, and I'm sure it's probably similar, I would think, to nursing and other disciplines, is that how much training do people get when they're in their education? And it's probably true with medicine as well. We've come to, I think, seen improvements in this. But in terms of looking at topics related to end-of-life and palliative care, if you look in that first column, you'll see that 65.8% of people who responded, the social worker said they got no training at all on palliative care. Now, again, this was a little over 10 years ago, so I'm hoping if we were looking at these data today for social work, nursing, medicine, whatever discipline you may be from, that those numbers would be higher, and I'm fairly confident that they would be. But back then, I think it was pretty rare that this content was covered in programs. I also asked people, and this is not included on the slides, but since your social work education, how much training have you gotten since then? And palliative care, that went up to 48.6%, so about a little bit more of an increase. Ethical issues, interestingly, went down, and only 2.7% had gotten any additional training in ethical issues. Legal went down as well to 9.7%. And suicide, or that PAS is physician-assisted suicide, went down to 16.4%. One of the things that really shocked me as a social worker is on the issue of family intervention. While about a third of social workers said they got training on family intervention in their bachelor's or master's program, when you look at training where people get postgraduate, post-bachelor's training, once they're out in the field, that number went down to 1.4%, and that was really surprising. So I think that this tells us that not only are there gaps in educational programs, which again are hopefully improved, but that we really need to think about what avenues we can get additional training when we get out of our training programs, that is really important to continue to update our knowledge. These are the National Association of Social Workers Standards for Social Work Practice in End-of-Life Care, and I'll give you a minute just to look at those. But I know that social work is similar to other disciplines, but maybe even a little bit more so because of our code of ethics. The principle of client self-determination is very, very important. And I think that as we look at some of these issues, that principle can actually add to the complexity of supporting people in their right to self-determination when there's so much at stake and decisions about the end of life are being made and people are making decisions about whether they want to continue to live or whether they want to hasten their death. And you'll see there in the middle that it says that they affirm the right of the individual to determine the level of his or her care. And they also mention mental illness, which we're going to talk about, as well as people being vulnerable to coercion or who lack decisional capacity. So those are some important things I wanted to point out. NHPCO had a policy, which we're going to get to in just a second. And as part of the study that I did, I asked people, are you familiar with that position? And it was sort of surprising to me that at that time only half of the people who responded to the survey were familiar with NHPCO's policy. But again, think of the time frame. This was pre or around the time of Dr. Kevorkian and a lot of things coming out. So, we may have seen this number go up in more recent years. But most people agreed with it. But the other thing that I thought was interesting was that most people did know the policy correctly. Now, if you look at the NHPCO policy back from when we did the study, this was at here on the screen from 1996, and that was a resolution rejecting it. And you'll see sort of the term assisted suicide and that NHPCO does not support assisted suicide. So then if we fast forward to 2005, this is the most recent that I was able to come across, and I think this is the most current resolution on physician-assisted suicide that you'll see there on your screen. And if you look at the last one, NHPCO does not support the legalization of physician-assisted suicide. So there is no resolution on suicide. But I did want to throw in the resolution on physician-assisted suicide. We're going back to the survey for a second. I want to talk about the agency policies on on suicidal patients. And I basically asked people, what is your hospice organization or agency's policy on how you deal with a suicidal patient? And not surprisingly, the most common was mental health referral. And these are kind of varied in kind of the approach, and obviously there may be some overlap between, and people could identify more than one thing. But I think that people are looking at, do we need to assess this as being a mental health issue, and how likely is it that this person can actually have the means to be able to act on this desire if they are suicidal. And then about a fourth using the doctor or the team to help them as a resource. So my next polling question, if you could take about 30 seconds, is, does your agency have a policy on suicidal patients at your hospice? So give everyone a second to respond to that. Okay. So of the responses I've received, this is great. 95%. Okay, it's changing a little. Give it another second. All right, we'll go with this number. 89% of those of you who responded said your agency has a policy, which is really great. I think we've definitely seen more attention focused on this issue since the beginning of when I started working in this area. The next slide goes into some detail about those cases. So as you'll recall, I asked people who responded to the survey, have you ever had a patient who told you that they wanted to hasten his or their death? And you can see that people in their career, and again, careers varied, but these were people who'd worked in the field about an average of 4 years in hospice. I had about 3 of these cases. And so if you think about this as being somewhat indicative of what might be happening other places, 1 request per year. Now, this is going on a little bit different of a tangent, but we also asked about family members who wanted to help the patient hasten his or her death based on the patient previously saying that they wanted to do so. So these numbers, as you'll see, are a little bit lower. So you go from half of people having a patient tell them, and then a fourth of people having a family member who's thinking about making the request on behalf of a family member. Who were these folks? So if you look at this, these are the demographics. of the actual cases themselves. So these are hospice social workers' reports of who the patients were in the hastening death cases. And if you go back to what we looked at about suicide in general, I think you'll see that these are not dissimilar in many ways, with males and Caucasians overrepresented in the data. And then you can just see the breakdown of their marital status and educational level on there as well. The age group, it's pretty varied, as you can see, but we've got the 50% of our folks are in the older adult range of 61 to 75. Then if we put that into including the 76 and older, you can say that a large number of these people are going to be on the older end, which I think may also just be a reflection to some degree of the hospice population. One of the things that I looked at and did some additional analyses, which I won't be going into detail about today, is the role of religion. And so we did ask people about their religious preference, and I think you'll see what we have there is probably fairly indicative in terms of religious preference in the region where the data were collected. Types of illness, these are the reports. So again, probably fairly consistent with hospice population, majority with cancer diagnosis. And the one thing that was a little surprising that we found is these are not people with psychiatric history. So while on one hand it is, on one hand it isn't, but I guess it depends on the perspective of whether we view these as being more mental health related cases or if we view these as more specifically factors that are unique to end of life, and I'll be talking a little bit more, and you all probably have your thoughts on how you view them. But one really important finding, and I'm hoping, too, that with time these numbers have improved, is that only 10% of these cases was a psychiatric consultation called in and the patient received. And I think you'll see as we go along sort of some thoughts about that for future work in this area. What exactly did the patient or family member say? So as you'll see, most of the time the patient made the actual request to say that they were considering hastening their death, with it less likely that the family member would be making the request or comment about hastening death. The other thing that's interesting, and again, we might have gotten different information if we had asked nurses or chaplains or whatever. That just wasn't the focus of the project and the research we were doing. But mainly the cases that the social workers were aware were cases where they were told. So in half of the time, the social worker heard the information directly as opposed to hearing it through another team member. And in a smaller number, about 1/4, the family member actually told the social worker directly. So there's about 3/4 of the cases that maybe family members are talking to other people. And so we already talked about that 90%. So what exactly did the person say? There were comments made that were really, really diverse, and so I think it's worth talking about these and somewhat specifically. A small percentage, but as you'll see there, asked for help and hastening their death. Other people made more general comments. Other people talked about specifics. Other people wanted somebody else to help them. And then talk of medicine, the role of medicine, about how they might either not take their meds to try to hasten their death, if the medication was something that was critical to them being able to stay alive, or they might overdose on their medication. It gets tricky when we get into these general statements about people saying, I want this to be over, I can't continue to live like this, life's not worth living. Some more of those more existential type comments to me are in a little bit different category than some of the more very pointed requests that people made. And lastly, which I think is important to look, we had that small number of people who expressed that they wanted to have more control over the situation of what was happening, and I don't think that that's an uncommon thing for people to want when things feel really out of control in their lives or with their symptoms. All right, we'll move on to the next polling question. For those of you in your computers, if you can indicate how many patients have you had, and this would be in your career, who've wanted to hasten their death. So if you can just take a moment to respond to that. Okay. only a very small number of folks on the phone, 3%, said that they had no cases. 3% of you said you'd had one. And these percentages are not going to add up to 100 because people are still putting in answers as we're going along, but they're still close to what they were. 2 patients, we had 10% of people say they'd had 2. 10% of people said they'd had 3. And this is big numbers. 4 to 10 patients, 40% of those of you on the phone said you'd had 4 to 10, and 35% of you had more than 10. So wow. So we're looking at 75% of people on the phone had 4 or more cases. So I think this obviously speaks to that this is a topic that's important to the work that you're doing. I'm going to move on to looking at perceptions in these cases. And again, I think we have to exercise some caution here because these were not necessarily things that the patient told the social workers directly. These were things that the social workers perceived to be going on with the patient and the family when there were cases where the patients wanted to hasten their death. So social workers perceived that the biggest issue they saw was pain and suffering. And as you'll see, quality of life, burden, and again, if you think about that loss of control, and that was mentioned in the previous slide where we talked about people actually stating that loss of control. Again, this is a limitation on this one too about social perceptions of people who report this to us, but you can see, and if you look at the literature on hastening death or suicide at the end of life, unmet needs always come up in the literature as being a big factor. So we asked them, what do you think the unmet needs were in these with patient or family situations? And you'll see a list there of how that kind of broke down. And I think the first one really tells us that people really struggle with the changes that they have in their lives when they have a life-threatening illness or terminal illness, and that there are many things that they can't do that really are difficult for them. And then if we also look at the other issues, depression, as about 50% of the cases was perceived. Now, this doesn't mean that there was a diagnosis of depression, but it means that people perceive depression to be an issue. This is just the same list continued, and you'll see family conflict, all types of things, suffering, lots of things that I'm sure you see on a daily basis in your work. When asked, what do you think, how much do you think unmet needs in that case contributed to the patient wanting to hasten his or her death, or the family member wanting to assist based on the patient's previously stated wishes? About 3/4 felt that those unmet needs were really playing a role. And as you see, a very small percentage thought it didn't play a role. So again, we're seeing that through the eyes of hospice social workers who are working directly with these folks, that they're seeing a lot of unmet needs, as well as feeling that made a contribution to the request or consideration. So why did these unmet needs exist? So these, again, are social worker perceptions of why the unmet needs were there. And again, we just see a variety of different things that were observed or perceived. What were the barriers to getting the needs addressed? And you'll see that the most common, but not by far, was physicians. And I mean, this could mean a variety of things, but I think at least in some of the cases it meant that the social workers felt that physicians were not responding in the way that they felt was needed to get the unmet need addressed. And then you've always got the issue of time and caseload and all those kinds of things. But then you've got, as you see in the latter part of the middle to latter, you've got family issues and the families, whether the family is willing or not willing to engage in some of these things that need to happen to be able to make changes to the unmet needs, particularly when we saw in the previous slide that family conflict exists. That's really, I think, plays an important role. The other thing I wanted to know, and again, I think part of this goes back to my own previous work in hospice of thinking when somebody, or just in end-of-life settings where I work, when someone tells you this, I mean, what do you do in that moment? Who do you tell? What do you say? So I asked people to tell me, who did you share the information with? And as you can see, and I think most of us would not all of us would say it's a good thing that people went back to the team and said, okay, this is what's happening with this patient or family, getting input and support from the team on how to handle that. It was a little interesting that in only about half the cases, the physician was told. So you all may have thoughts on that in terms of how that might work in your own settings and the work that you do with families. And then families were told in about half, and then a variety of other people were told. So we asked what was the patient or family member planning to do. And you see the list there. And I think this, the fact that it's overdose, a lot of times when I talk with people, this concerns people, particularly providers who are prescribing the medications. There can be concern about, is that person going to use the medication that person has prescribed, and what is the liability on that type of issue? That can get very complex. And if we go back to the firearms that we talked about at the beginning, again, firearms a big risk factor, and about a fourth of these people were considering using a firearm to shoot themselves, take their lives, and some involvement here for families, maybe getting involved in giving medications that the patient had asked that they do, and then the rest of them, a large bulk of the cases, it was just unknown. General comments were made, things were said, but we don't have an actual specific about what they were planning to do. So this is on the list of interventions that the social workers used. As you can see, predominantly things that you would expect with social workers in hospice setting, counseling, and trying to do some intervention around the suicide, increasing the amount of contact, as well as contracting. So then we wanted to know not only what did they do, but what were they trying to do? Because I think this gets complex in terms of what is the goal, and I think that people may have very different opinions about what is the goal and what is your role in working in a hospice setting in these situations. So the most common thing is you see on the slide is that people wanted to provide counseling and be able to reduce the suicidality and look at safety, as well as different symptom issues. And so I think that makes sense given the role of the people who responded to the survey. The resources used, again, these are similar to what you might expect, the team, other types of resources. And hospice resources, we asked what type of resource within the hospice, in addition to the team, who did you bring in, or what did you use in these situations? And you can see just a lot of variation there. So we'll wrap up on this part by talking a little bit about what happened in these cases. And as you can see, that in about a third of the cases, the patient ended up not hastening his or her death. And I guess we'd have to have a little caveat there to say, to the extent that that was known, and that at the time we collected the data, there were still some unknowns, because a lot of these patients were still, I guess, current patients, and they didn't know what the outcome would be. And we only knew of one case that was reported in our data out of the 54 cases where the patient hastened their death. Barriers to intervention, and this is similar to some of the previous data that I've presented, but there are a variety of reasons why it can be hard to intervene in these cases. And some of the time, patients and family members just may not cooperate with the intervention that maybe the team has set up, or there are other factors that play a role in whether or not the intervention can be successful. So we'll move on to polling question number 4. If you can go to your computers and tell me how many hospice patients you work with do you believe have hastened their deaths? Okay, we'll give another second here. All right, 23% of you had none. About 19% had one patient. 28% had 2, 15% had 3, and 17% had 4 to 10, and 4% of you have had more than 10. So as we can see, if we look at it now with the updated numbers, 83% of you have had one or more cases, which I guess makes sense that people are on a webinar, because I think these are very, very difficult issues to deal with. Last information about the hastening death cases, people reported on some past cases, and back then a much smaller number than what you all are reporting. Only 12% had a patient hasten death without telling them in advance. And again, these are very small numbers, but in about 2/3 of these, or 3/4, the social workers thought that the family members were aware, and in half of them, the social worker thought the other members of the hospice team knew that the patient was going to hasten their death. So that shows that, I think, even though this is small, I mean, I think, and I'm sure you've all would have had these situations, know that people handle them differently, but that sometimes people do have a sense in advance that these kind of things may happen. And again, you'll see most commonly with a small number of cases, gunshots. How competent did people feel in these? You'll see that about half of them felt very much able, and then the other people felt somewhat or not at all prepared to handle these types of cases. And these are the outcomes that from the final cases. And that's a little bit of a repetition of the previous slide. So I want to go on to some more recent data, and now I'm going to move on to the second half of the presentation to wrap up on some of the other data. And some of you may have seen this article that came out. And I do want to back up and say that the data that I just presented have all been published, and there's a reference list at the end of the webinar. And if you want to see more detail on the slides or any of the methods, then those are all outlined in the articles that I've published on the data that I just presented. This is actually from Warren and Zen, an article that came out in 2010, and they did a chart review of both rural and urban hospices, and you'll see they reviewed 5 cases. And these cases that they present seem very similar to the ones that I think I just presented. If you see in the prevalence of males, cancer, the gun, the use of a gun, the military. But interestingly, note that in these reviews that right before the patient committed suicide, there was a marked decline in their functioning. And the authors really made note of that was of interest. And that these were not cases in their chart review where the staff really knew. People were surprised that this had happened, and that these patients had died. So this is more of a personal question, and again, this is an anonymous way of looking at how people feel about this. But those of you out there, if you can give me your thoughts on, do you feel hospice patients have the right in certain circumstances, not in all circumstances, to hasten their death? Okay, so 83% of you said yes to that question. 83%. Sorry, that's a duplicate slide. I'm going to skip over that. So the next topic we're going to talk about is suicidal intent. Particularly, what does it mean in hospice? Because having worked in both end-of-life care settings and in mental health settings, I would say that there are some differences in how suicidal intent is thought of, as well as how it's addressed in different types of settings. And hopefully at the end, when we have time for some questions, if people want to comment on that. To move into the section, I'd like to have people take a moment to review this hypothetical case of Bob. So if you'll take a moment and look at the case of Bob, and then I'm going to ask you a question about that. Hopefully everybody can see this, but I'll just hit the high points. Bob has end-stage colon cancer. He's married. He's got 2 kids. Since his diagnosis, he's become increasingly sad, depressed, withdrawn. He's been very concerned about his wife has been very concerned about his emotional well-being. His pain is well managed, but he reports frustration. He can't do the things he used to do. So he says to you, if I get where I can't do much more for myself, that's it. I'm not going to lose my dignity. I used to be able to do so much. Don't discuss this with my wife. So he tells you he doesn't want his wife to know. He doesn't want her to be implicated in any way. So tell me if you will respond to this question, which of the following is the best option at the moment? So I know that it might depend on the situation of later you might have some other thoughts. But in that moment, if you'll rate what you would say is the best option for Bob, dealing with Bob. Maybe like a few more seconds for those of you who haven't had a chance to respond. All right. So as you can see from the choices provided, that the first option would be just you don't say anything directly. You just kind of listen to what Bob has to say and follow up with your supervisor or colleague later to discuss how to manage that. I think the downside of doing that, and no one selected option A, that was a 0% from the audience listening to the webinar. I think the downside of that, which you probably see all the time, is if someone says something like that and you don't comment, then people don't know how to interpret that. So they may view that as you're supportive of that you don't think it's important, that you don't care. And so I think in these kind of situations, you wouldn't want to go with option A, which no one did. B, where we said you have a seat and talk to Bob more about how he feels and what he means, and then keep it to yourself. Having a seat is probably a good idea, and that's something that could also be a part of A. But the downside of keeping it to yourself is you probably don't want to be in the situation where if Bob decides that tonight's the night he's going to act on this or tomorrow, and you're the only one left with that information. That's usually not a good position to be in. And also, he may have made the only comment he's going to make before he acts on it, and you may not have a next time to be able to have that conversation. So no one said B either. Our most popular and only answer, and this is interesting, no one said anything but C, is have a seat and talk to Bob about how he feels and what he means, and then contact your supervisor when you leave for consultation. So I think everybody is in agreement on this. About you really need to sit down and talk and get more information, but you also don't want to be the one holding this piece of information to yourself, and that sharing this information with your supervisor and with the team is critically important, which is really one of the benefits, I think, of being working for hospice is that you have a team of people. And when you work in other settings, you don't always have that kind of support. A lot of times you're by yourself. And D, no one answered D, but the issue of telling Bob you must report this to your supervisor and the team, I mean, that's an issue that I think is something to think about for the future, is to whether at what point do you actually tell Bob, well, I had to share that with my supervisor. I couldn't keep that information confidential. That's something that you would have to decide, but I also think there's some benefits to telling people, what you can and cannot keep confidential. And I'm sure it's usually made clear that information that is shared usually amongst the team. But again, this is not information that you want to be the only one holding on to, and I think we're all in agreement on that. I'm going to move in as we look at is a request for suicide or a suicidal intent different in hospice. These are just some general principles, and they're kind of old, but I think that they're really important to look at, because even now I think there's still sometimes a misperception that people commit suicide just completely without warning. It's just something they do. Now, that's not the rule, but the data on suicide, again, not specific to hospice or end of life, but just general suicide data, is that 30% of all suicide attempts are impulsive attempts. So are there some people who impulsively make a decision to kill themselves? Yes. I would say that most likely, and I don't have data to support this, it's more anecdotal, that probably that number is much lower in hospice. that usually these are people, I think, who are really thinking about this. And so I would say that the likelihood of an impulsive attempt is relatively low. But again, no one studied that to my knowledge, and so that is what I would venture to guess. And the second misconception, I think, is I still hear people struggle with this, particularly like with even people who work in the field and professionals. Well, if they're talking about it, maybe they're just asking for attention. They really won't do it. If they were going to really do it, they won't tell anybody, and that's not true as well. In fact, in working with a lot of people who've survived suicide attempts, people will say, well, it really upset me that they thought I wouldn't do it, so I was going to show them. I was going to go ahead and try to do it because they didn't take me seriously. And the stopping people, again, that has to do, I think, if you relate that to the work that you're doing, the idea that people who really want to die will find a way, it won't help to try to stop them. I mean, I think that there are things that can be done effectively to intervene in many of these situations, but maybe not all, and that's something to really give some thought to. The idea that if you ask some people about suicide, that's going to make them think about it. There are lots of studies that are definitively established that that is not the case. People still think that. We still run into that issue in doing some of the work that we do around suicide research, that people say, well, if you ask them about that, are they going to think about that? Well, if you really think about it, that these are people who, many of them, have been thinking quite a lot about this. If you're not suicidal, and somebody asking you about it is not going to all of a sudden make you want to change your mind and think about suicide. So that is still a very commonly held belief, but is not supported by the research. And then the other two, I think, are important but not as relevant, so I won't go into detail on those. So these are some thoughts that I had that are also adapted from an article that just came out last year by Marks and Rosiel. I think I'm pronouncing that correctly. So it's sort of a mix of their thoughts and mine as well. But I think if we look at suicide in general, like, we know who's at risk. National suicide data, suicides are tracked nationally, at the state level, locally. I don't know what it's like in your communities, but in our community we can look and get access to data for our county and know how many people committed suicide in a given year and get some demographics. But we really are clear on who's at risk. And we know that there are people who are going to make another attempt, but that's at about 20% if you just look across the board in general suicide. And I think pretty much we assume that mental illness must play a role in people and from the general population who commit suicide. And the research supports that people with depression and different mood disorders are at higher risk for suicide. But I think people think when you hear somebody from the general public that committed suicide, one of the common things people think is, oh, what happened? I didn't know they were depressed. I didn't pick up on any of the warning signs or things like that. If we then go from sort of the general population of suicide to looking at suicidal intent at the end of life, one of the most important things that the authors of this article point out, and it's a really good article, I'd recommend people checking it out, and the reference list has the full citation at the end of the webinar, is that the rates of attempts among people at the end of life are unknown. We don't have any epidemiological data on suicide attempts at the end of life. So we can look and we can tell you what percent of the U.S. population makes an attempt, what make a completed attempt. But at the end of life, we have no statistics on those types of data. So what we rely upon are similar to what I presented to you today, studies that have looked at it in their own sort of samples at their medical centers or in their communities, but we don't have a lot of national data. The other thing that we know is that there's a somewhat of a unique set of risk factors that come into play. And the authors of this article really talk about these issues as well, is that if we look at rates for people with cancer, those people have 2 times the rate of suicide risk of the general population. So cancer alone can increase your risk. And if you look at the types of cancer listed there that have the highest risk, and if you think back on your hospice population of people that you work with and the cases where you've seen this, and maybe this is something people could comment later on in the chat that I think would be interesting, is where those people lung, stomach, or head and neck cancers. because I think we would probably all agree that those can be really, not that any type of cancer is easy, but some of those can get really complex with symptom management. And the other thing is that if you're in the general population and you don't have a life-threatening or terminal illness, death is not something that you typically talk about. Some people do, but it's not a common thing that's on the table that people already are acknowledging. But when you're at the end of life and you're in hospice, death is really already part of the discussion. People have already been told their prognosis. So they're talking not just about their death, but they're specifically talking about whether they want to hasten it, whether they want to speed it up and have some control over the timing. We don't usually have those conversations in general suicide prevention. So I think that makes it really unique. At the same time, it makes it really complicated. Some of you may know the work of Linda Ganzini, and I don't know if we have any folks from Oregon on the phone, but Dr. Ganzini is very involved in research and work on physician-assisted suicide and has published a lot on these issues. And this is a quote that she had from 2010 that I'll just read out loud. These people prize independence, autonomy, self-sufficiency, and control. They want to leave this world in the driver's seat, and they anticipate a dying process that is incompatible with this goal. So these people that she's speaking of are people who were requested assistance in dying with physician-assisted suicide in the state of Oregon. The interesting thing to note that was also part of the article where I took this comment is that 95% of those who die with physician-assisted suicide are enrolled in hospice. So I think that really makes it interesting. And if you think back on the cases that you've been involved in or the cases that you have now where these people are thinking about these issues, my guess is that you probably see some of these issues about control, independence, autonomy, and really wanting to be in the driver's seat at the end of life versus having that feel like something over which you have no control. This is a study from about the same time when I did my earlier study that I just thought brought up a few interesting points. And I'll say, that what people say they may want may not actually be what they want, and I think that you probably see that in cases where people think they want to hasten their death, that when it comes down to it, they may or may not. But they studied terminally ill people, and they found that, as you see there, 60% supported hastening death in a hypothetical situation. So they weren't necessarily asking about them themselves, but then a smaller number, as you see there, reported considering it. So if we look at that as maybe somewhat of a baseline, 10% of folks considering it for themselves in their study. But if you look at there at the last two bullets, if you fast forward it a little bit, half of the people are changing their minds either way. So some who've considered it changed their mind to not considering it, and some who weren't considering it decided that they were. And if you see the symptom list there with patients who are more likely to change their minds and consider it, I think that's important for the work that you do in terms of symptom management. So what about the providers? So we'll talk a little bit about your role. And this is a study by Russ Portnoy from the late 1990s. But I think that this is important as you think about yourselves and the role of what you bring to the table and the work that you do. These are factors that he studied. He surveyed healthcare providers and looked at their willingness to support physician-assisted suicide. So it's really specific to that, not suicide in general. But those are the qualities that predict the willingness to endorse it. So again, I mentioned the issue of religious beliefs earlier. That was something that came out here. I think the other thing that's important is if we look at symptoms possibly playing a role or unmet needs, people that tended to support it more were the ones that felt that they had less knowledge about symptom management, pain management, not rated by other people, but that was their perception that they had that. And then social workers were more likely than their colleagues in medicine and nursing. And I kind of wonder if that has anything to do with the social work commitment to self-determination that's as specifically stated in the code as it, I don't know if it is as explicitly stated in others. So other myths that we come up against are, and I've probably had conversations with people about this for 20 years, is that, well, who wouldn't be depressed if they were at the end of life and had a terminal illness? And that is true. I think certainly for many people, but not all, depression is something that people struggle with at the end of life. But just because it happens and just because it's common doesn't mean it doesn't need treating. And I think we would say that if somebody had lung cancer or COPD and they were having trouble breathing, we might say, well, that's normal at the end of the course for that illness. But does that mean that you wouldn't try to do something about it? No. The same applies for depression. People at the end of life who are depressed, I would argue, really need access to the same resources to treat the depression. Now, the cause of the depression, if it's related to their feelings about their death, that there may be nothing you can do about it. But I think that we clearly know that many of these people do respond to treatment that can improve their quality of life if they're depressed. The research suggests that having people sign a contract doesn't protect people from killing themselves overall. But I will say in situations where you have a close professional relationship with someone and there's a lot of trust built up, and I'm sure that's the case in many of the cases where you work with folks, sometimes there is that sort of commitment that people aren't going to let you down. So would I say never contract and write anything in writing about that they won't agree to kill themselves without first doing, certain things to try to reach out for help? No. But would I feel secure that that's going to seal the deal, that nothing's going to happen? No. So I like to think of them less as suicide contracts as safety plans, where I specify with people, if you start feeling this way, this is what you agree to do. And then you spell it out in writing that this is what you're going to agree to do, and you ask them to adhere to that plan. So really the goal is getting them to agree to reach out for help, not agreeing not to kill themselves, but you hope that would be the end result. And the other myth I think that we see is that people at the end of life commit suicide in a way that we'll never know. And if you look back again, there's small numbers of these cases that we've seen with hospice patients, both in the data I presented from the work that I've done other people. We're looking at primarily gunshots. So I think that the data suggests, although they're limited, that this is not the case. But I'm sure there are those cases, and I'm not going to dispute that. But I think if we're talking about people where we can really make a definitive judgment that that's not something that is a huge issue. So how do we assess and intervene in these cases? And I'm thinking that probably a lot of you already have your assessment tools that you use. You have your procedures, which is great. Again, that wasn't something that was in place when I was back there, many years ago, wondering, oh my gosh, what do I do? I have no idea. What do I say? What do I do? What class was this covered in graduate school? I mean, these were things that were never covered, and I thought, did I miss this? But I remember that feeling of saying, what are the things I need to try to find out? So the first thing, and I think that hopefully people would agree with this based on our case about Bob, is you got to get more detail. You've got to be comfortable to have a conversation with the patient about what he or she is thinking. And those can be scary conversations, particularly if you're new to the field and you haven't had a lot of those. But I can say to you as someone who works with suicidal people on a almost probably daily basis, is that you have to feel comfortable having the conversations and getting into the nitty-gritty with people and really hearing about what they have to say. And that can be intense, and that can take a lot of time. But I think those are really important conversations because most of the time people want to be heard and they want to be listened to. And it's really not about just figuring out what you need to do. There's more to it about actually listening to their story and finding out what's going on with that person. But the other more specific things that I think are important to do are to look at the person's psychiatric history. Again, in my work, I found that like 80-something% of the people didn't have psychiatric histories. But if they do, that's going to put them at higher risk. So I would look at that, but you don't want to assume that no psych history, there's not risk, because that's not necessarily the case. Substance abuse, does a person have a substance abuse history? Again, if you mix psychiatric and substance abuse in the general suicide work, we'd say high risk. But I was going to say, if we go back to, is suicidal intent different in hospice, I would say these two last ones, those are the two of the really big ones, is what is going on with this person that is unmet? What are the symptoms? Are there unmet needs? Are there symptoms that are poorly managed that person really needs to have addressed where they can feel like that they would not have that suicidal intent? And who do they have around them? who do they have in their support system? In some of the cases that from the other studies, they found that a lot of these people tended to live alone and or spend a lot of time by themselves. So that's something to think about. So when you specifically look at the part of your assessment on suicidality, again, presenting concerns. What are the concerns? Some of them may be symptoms, but some of those may not be. So if you go back to the issue that we talked about earlier about control, if the person is wanting to have a lot of control, then I would find out in what areas of their life do they feel out of control. You may have your own perceptions, but I think it's really important to hear it directly from the patient and then try to figure out how can you enhance whatever level of control. It may not be that you have any control over certain things. Certainly at the point where you're working with them, you may have no control over the prognosis or it may be certain things about the disease process that lie ahead, but maybe there are little things that you can do, like maybe they can have control over certain things in their home, certain decisions that they make, that maybe other people are doing things for them and they want to be more independent. The other issue is that culture plays a huge role, and I think that this could not only be racial and ethnic differences in how people perceive these issues, but also geographical differences in different parts of the countries, how these issues are addressed in local communities, and it's really important to examine those and how they may be playing a role. Family support, for people who have limited family support, I think you're going to find that those are people where you really want to see if there's not that support in the home or wherever you're working with that patient, are there other people that can be brought in? Can more volunteers be brought in? Can other members of the hospice team be brought in to give support? And I would ask very direct questions about intent. What are they planning on doing? How likely is it that they would do that? How fearful are they that they might act on that in the spur of the moment in more of an impulsive type situations? Again, you can ask them very specific questions, and there's just a few specific examples there. The other thing that I think that hopefully people saw from the data that I presented in this webinar is that not all the statements are going to be the same, nor is all the intent the same. I think it's really different to say, I can't deal with this anymore, I can't live in this much pain, versus when you leave here, I'm thinking about taking a gun out of the closet that I've hidden in a shoebox and killing myself. Those are two really different things. And so I think we have to realize and keep that this is a continuum of potential intent and lethality. And some of these people are really heading towards that end, but other people are suffering. They're dealing with these issues, and that all those requests aren't going to necessarily mean the same thing. We talked a little bit about this earlier in the situation with Bob, but I would say don't be the only one with the information. You don't want to be left holding the bag when something might go wrong, and you might be later looked to as, why didn't you share that with the team? Not only for that reason, but these are hard cases, and I know how difficult they must be for all of you, having been involved in some myself, that you want to get support from other people on the team. You want to bring people in. Don't hesitate to ask specific questions to the patient and family. And other people may, and I don't know how your hospice has handled this, but I've always been trained in, if you don't document it, it didn't happen, and that you document everything that you did and the interventions that you did on behalf of the patient. Again, that may vary by site in terms of how they want that documentation done. Any time when you feel there's a risk of a patient committing suicide, this is just standard suicide prevention, I would recommend that you remove the firearms and decrease access to medications. But the firearms, if you do one thing in suicide prevention to help, it's remove firearms. And I'll say, as having lived all my life in the South, that can be really hard to do, because a lot of times people don't want to remove their firearms. But then if they won't, then you can put some other safety measures in place, like putting a gun lock, having the bullets be stored, separately from the weapon, and having things locked up. Warren and Zen, the article I mentioned earlier, has some really good things that they talk about, not just at the local level, but that we should be doing nationally here. And they talk about developing a checklist for those at high risk and using that. I know that a lot of times on inpatient psychiatric units, when people come in and they're suicidal, they are using checklists to look at suicide risk and using that as an indicator of intervention. Warren and Zen talk about doing the same thing for people at the end of life. They also talked about developing, similar to the checklist, a protocol And the word they use, which I wanted to highlight, is meticulous attention to symptoms, where we really look at specific symptoms and how intervention can be targeted to those that might be linked. Again, this is all tracking to suicidal intent. Again, we see they talk about the firearms and this issue of control. So I think we're starting to see some themes as we sort of go through the presentation of things to really, really look at. And when you do have a situation where someone hastens their death through suicide or assisted suicide, I think it's really important to debrief with the family, but also to have debriefings for the staff. And so I don't know if you all do that, but I would really encourage you to have debriefings either with supervisors or hopefully with teams. I know working in mental health, when we do have situations where people die, it's not always a systematic way that we address that, and it's hard on people. These can be really difficult cases. The other thing that they have recommended is to track hospice suicides, and I think by this they're meaning like almost like a registry, like in a national database where people could gather this information, and I don't know if this is of interest to people or if this is anything NHPCO could be involved in, but as you can see, we have very little data on these cases in hospice, and so I think that would be really interesting and informative to be able to help people if we could figure out some way to try to be involved in tracking these. So I would say that the unanswered questions in these situations are, do we treat terminally ill persons the same as any other person who wants to kill him or herself? And what is your ethical responsibility in these situations? And so I'm going to quickly talk a little bit about these things because we're almost out of time, and I want to allow some time for questions. Interventions for suicidal intent, those are pretty straightforward. We've talked about a lot of these. Supporting the family, get help for yourself. I don't really have a lot of time to talk about this, but I know that in hospice you guys do a great job of talking about grief. But I think with suicides, we want to be really concerned about the small percent but important percent of people who have complicated grief after the suicide. And then these are some of the complications of grief. This is from an article by Young, and that, again, is in the reference list. I'd really recommend that as a resource on this, because a lot of people, too, you'll see, I'm sure you've seen anger, God, deceased person, family members, and maybe even at you all on the hospice team. Intervention for families, what do we know works? And Young talks about these three in more detail. But suicide completion, working with families, there are three evidence-based interventions they recommend. The first is cognitive behavioral therapy, which I think most of you are probably familiar with, what they call time-limited interpretive group therapy, and I'm no way an expert on that. I'm going to let you guys look that up. But another is called complicated grief therapy, which is like interpersonal therapy, which is a pretty common treatment, evidence-based treatment for depression, where you add in other techniques. So these are things to consider if you don't already, maybe in your bereavement programs. One thing that I found that you may already be aware of, but I was not till I sort of was looking at some of this information, a great tool by the authors listed there that was published in the American Journal of Hospice and Palliative Care. They actually have a list, the actual tool itself. It's a risk factor assessment for complicated bereavement. And those are the risks that are rated as most common among people in complicated bereavement. But if you're looking for something you could use to say who's at risk for complicated bereavement, probably everybody where a patient is hastening their death, look at that tool, and I think that's a great resource. So final thoughts for hospice staff. I would know where you stand on these issues. Obviously, from our little polling question, many of you think that in certain situations this is okay for a patient to hasten his or her death. I would think about what are the lines for you. Where do you draw the line? What do you think are the important things to think about in those situations? How do your personal values play a role? Because I think we're all kidding ourselves if we think that we don't bring something to this in terms of who we are as people, and how do our own personal values play a role? Know the laws and take care of yourself. I know that the work that you do is very difficult, but so important, and I would encourage you all to take care of yourself, especially when you lose folks. So that is the end of the presentation. I'll turn it back over to the moderator.
Thank you, Dr. Arnold, for such a great presentation. It's now time to get your questions answered, everyone. You can ask a question to Dr. Arnold by typing your questions into the chat box in the lower left-hand corner of your screen, or if you're listening over the phone, you can press *1 on your phone now to enter our phone queue to ask a live question. We do have a couple questions in here already that we can get to. Our first question here for you, a person writes in, I have recently heard that suicide is no longer illegal, and that impacts the fact that we are no longer a mandated reporter. Can you speak to whether this is true or not?
Can you repeat the first part of the question, that suicide is no longer illegal?
Correct. And that impacts the fact that they are no longer a mandated reporter.
Well, and there may be some state variation, but, I mean, to my knowledge, there's no place where suicide is actually, considered a crime. So, I mean, people, in theory, are free, if you want to think about it that way, if they decide that they want to do something in some manner to harm themselves. The issue becomes, I guess, depending on your discipline and your role in your hospice policies, do you have a policy that says that people are required to intervene? And if you're a mental health professional, or you're an LCSW or an LPC, or then there are professional guidelines about what you need to do when somebody is feeling suicidal. And the way I always explain it to people is that if you tell me you're going to hurt yourself or anyone else, I'm obligation to try to intervene to try to help you. And so, if you're licensed to do that kind of work, then you have to follow those rules about trying to do an appropriate assessment and intervention. But people can't be charged criminally, if they try to kill themselves, but you could be potentially held liable if you don't do what's appropriate within the standard of care for your profession in those situations.
A site has stated that they have had a difficult time finding a good assessment to use for hospice patients. Is there a good tool out there that can be recommended? And also, does anyone have any guidelines or policies that they would be willing to share? The policy they have in place is just not clear enough for their staff.
Well, I think hopefully on the latter issue, maybe some other people can respond and give their contact information that the site could use as a resource. Unfortunately, I don't know of any standardized assessment that is used. Maybe some other people out there. I mean, in terms of the complicated bereavement that I mentioned at the end, that is a really good risk assessment tool. That's actually, the whole tool, as I said, is published in that article. So there is something out there for complicated bereavement. To my knowledge, and I've recently, before doing a last-minute update on this presentation, I did not see anything that's a standardized assessment tool. But if you go to the literature and you kind of look, and I've got some things mentioned in the reference list, there are a lot of components that are recommended to include, but I don't know of anything that pulls it all together in one place.
And do we have any live phone questions in our queue?
And there are no questions at this time. As a reminder, it is *1 if you do have a question.
We'll move on to our next chat question here. How do you go about getting guns out of a private citizen's home, since they have a constitutional right to own them?
That's a good question. You can't actually get them out, nor can you force somebody to get them out. But what you want to do is talk to whoever I think is owning the weapons and explain to them your concern. So in this type of situation, with the patient's permission, but in hospice, I know that you're working with the whole family, so you have that. You want to say to them, I have concerns that, if we go back to a situation about Bob, I have concerns about Bob's safety, and I'm recommending, hopefully consistent with our policy on assessing that, there's some concern here about this, and I'm going to recommend that you remove the firearms from your home. Now, that person can say to you, no, I'm not going to do that, and that's where I go to that second thing of like, well, what would you be willing to do to ensure that Bob doesn't get access to have access to the firearms? Would you be willing to take it to the neighbors? Would you be willing to lock it up in a safe? Would you be willing to remove the guns from the bullet and keep them separately? Would you be willing to put a gun lock? So, yes, people have a constitutional right to own firearms, and in the part of the country where I live, it's very, very common. But if you explain to them that you're not trying to take away any rights that they have, you're just doing this out of concern for the safety of the patient, then most people will come around. And I've dealt with this, for many years, and I can count on one hand probably the situations where we couldn't get it resolved to do something that we all felt good about.
Our next question, do you have an example of a checklist for high-risk suicide?
A checklist. I don't have a checklist per se, but there are a lot of standardized measures for suicide that you can look at that are out there. And one of the most common one is by Beck. It's a suicide scale. There's other scales. I don't know of any offhand that are normed with people with at the end of life that can sort out a lot of the somatic symptoms from the depressive symptoms. But if you do a search online and look at some of the stuff, you'll see the ones that are commonly used. The one I've used in my research is not one that's as commonly used, which is the Generalized Contentment Scale. It's a copyrighted scale. But if you do a little bit of search in the end-of-life literature, you'll see that there are several, that including the Beck, that are commonly used that you might want to check out.
Okay. We have a couple questions here about patients with dementia. How do you assess and intervene with the patient who has moderate dementia and suicide ideation? And also, how do these factors differ for patients with dementia where their decision point would be earlier in the progression of their disease?
And that is a really, really complicated but important question. And I will say to you that most of my work is really around people who are not experiencing dementia, so that is not my area of expertise, and I typically defer to colleagues on those cases. I will say to you, though, that those folks, certainly have some diminished capacity to make rational decisions. In those cases, I would really involve a psychiatrist or a neuropsychiatrist to come consult on those cases and give you some guidance, because those cases can get so complicated. So you're not only dealing with somebody who's got all the other issues associated with suicidal risk, but dealing with the cognitive complications. And so I would recommend bringing in somebody with that expertise on those cases, because those are very, very complicated.
Okay, great. Well, we've run out of time for questions, so we're going to just take one last one here. Is choosing to stop eating or drinking considered suicide?
Well, that's a good question. I would not necessarily consider that suicide personally. I would consider that, though, a means of hastening death. And so, a lot of this is really sort of about semantics. But, I think if somebody's purposely restricting, food or fluid to try to end their life, then I would say that I would apply some of the same principles and methods of assessment that I talked about today. Now, whether or not you call that suicide, I would probably say no, but I would call it hastening death, and I would still do the same things that we've talked about today in terms of assessing, looking at unmet symptoms, looking at depression, and looking at these same things to see what's going on, because it's really just a question of means. But I think those kind of cases, you're looking at a lot of the same issues that we've talked about today.
Great, thank you. Any questions that were not answered today, we will follow up with you after the webinar. Dr. Arnold, any final closing remarks for our audience before we end today?
I don't think so. I just want to tell everyone that the work that you do is important, and these are important but complicated issues, and I wish everyone the best as they deal with these out in their practice.
Well, thank you, everyone, for participating in today's webinar. Please submit your individual attendance, evaluation, and CE/CME credit forms with payment for those requesting CE/CME credit within the next 5 business days. Each participant in today's webinar is requested to submit the form or complete it online per directions emailed to your site coordinator, regardless of your desire for CE/CME credit. Your registered attendance and evaluation of the session are very important to NHPCO's education team. And that concludes this NHPCO webinar. You may now disconnect.